name's Kate Chesterman. I'm a salaried GP in South Norfolk, and I also co-host the GP Notebook study groups. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple, and Google Podcasts. Please follow us to receive notifications about new episodes, and if you like what you hear, please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GP Notebook for more information about new podcast episodes and study groups. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Today, I'm going to be discussing breast pain. We're going to consider the different types of breast pain and their causes, the assessment of a patient presenting with breast pain, as well as primary care management options and indications for referral. Breast pain affects around 70% of women at some point in their lives, and it's a common reason for presenting to primary care. It's also a common reason for patients to be referred to secondary care, with breast pain constituting up to 41% of attendees in one-stop triple assessment clinics. Breast pain can be divided into three categories: cyclical, non-cyclical, and extra-mammary. Cyclical breast pain accounts for 2/3 of cases of true mastalgia. It's thought to be related to hormonal changes throughout a woman's menstrual cycle, and it might be exacerbated by prescribed hormonal medications. It commonly occurs in the luteal phase, towards the end of the menstrual cycle, and builds until menstruation begins. It's usually alleviated by the onset of menses. Cyclical breast pain is usually bilateral and is often described as dull, heavy, or achy pain. It's often poorly localized and can radiate to the axilla. Non-cyclical breast pain accounts for the final third of cases of true mastalgia. Non-cyclical breast pain does not change with a patient's menstrual cycle. It can be constant or intermittent and affect one or both breasts. It can occur because of pregnancy or prescribed hormonal medication, as well as other medications such as SSRIs. It can occur secondary to breast conditions such as fibrocystic disease, diabetic mastopathy, trauma, thrombophlebitis, previous breast surgery, and even malignancy. Inflammatory conditions such as mastitis or breast abscesses will also cause pain within the breast that is not cyclical. Extra-mammary pain is pain occurring from structures outside of the breast, and it is actually the commonest reason for a breast pain referral to secondary care. Causes can be musculoskeletal in origin, such as costochondritis, or soft tissue, rib, or vertebral injury. It can result from fibromyalgia, herpes zoster infection, or referred pain due to ischemic heart disease, peptic ulcer disease, gallstones, or gastroesophageal reflux. The assessment of a patient with breast pain should include a thorough history. This needs to cover the nature of the pain and any exacerbating factors such as activity or trauma, as well as any association with the woman's menstrual cycle. If it's not clear whether there's a cyclical pattern, asking the patient to complete a breast pain diary for at least 2 cycles can be very informative. I've put a link to a pain chart in the show notes for this podcast. There are plenty of different ones available, but this one, from Breast Cancer Now, seems very user-friendly. For those with cyclical pain, it's also worth asking about other physical or psychological premenstrual symptoms. If these are present, then you may want to consider a diagnosis of premenstrual syndrome, and there is very good guidance available for the management of this condition. We need to ask about any breast changes that may be associated with malignancy, such as nipple discharge or a lump, and we must also inquire about any past medical or family history of breast or ovarian cancer. If a patient has a moderate or high-risk family history, then they should be referred to a family history or genetics clinic for further assessment. We should inquire about the possibility of pregnancy and check the patient's caffeine and alcohol intake and whether they smoke. Ask whether the patient is taking any hormonal medication or other medications that could result in breast pain, such as SSRIs. And finally, ask if there is any history of breast implants or tissue expanders. Our examination should focus on a thorough assessment for features of breast cancer, such as a discrete lump, skin or nipple changes, or lymphadenopathy, as well as for inflammatory findings that may indicate infection, such as erythema, indurated skin, swelling, and focal pain. It is worth being aware that inflammatory breast cancers can present with similar clinical findings to infections, but are not usually painful, and the inflammatory changes do not resolve with antibiotics. Any finding consistent with breast cancer, including inflammatory breast cancer, should be referred on an urgent suspected cancer pathway. Concerns about breast abscesses, severe or non-resolving mastitis, or sepsis will need escalating immediately. An examination is also helpful when assessing for extra-mammary causes of breast pain. We may, for example, be able to see a rash from a herpes zoster infection or bruising from a fall. If examining for chest wall tenderness, it can be helpful to place the patient in a lateral semi-recumbent position, as this moves the breast slightly away from the chest wall. If palpation of the area reproduces the patient's symptoms, this will increase our confidence in a diagnosis of chest wall pain. So, let's go on to consider the management of breast pain. First and foremost, acknowledging the impact and severity of the patient's symptoms, as well as explanation and reassurance, all have a vital part to play in the management of the patient with breast pain. Understandably, many women are worried that their pain may indicate breast cancer, and we need to reassure patients that, in the absence of any concerning clinical findings, breast pain alone is not indicative of breast cancer. In May 2022, the Association of Breast Surgeons issued a statement on breast pain, stating that the incidence of breast cancer in women with breast pain-only symptoms, so no lumps, nipple or skin changes, was 0.4%. And this is actually a lower incidence compared to asymptomatic women invited to the National Breast Screening Programme, where the incidence of breast cancer is 0.8%. In addition to a lack of association with breast cancer, cyclical breast pain resolves spontaneously within 3 months in around 20% of women, although it recurs in 60% within 2 years. And although non-cyclical breast pain sometimes responds poorly to treatment, it also tends to resolve spontaneously in around 50% of women. Trials looking at management options for breast pain tend to be small and of relatively poor quality, but several suggestions are frequently recommended which have been shown to be of benefit. Combining several of these suggestions concurrently is likely to be more effective than using them in isolation. Whether the pain is cyclical or non-cyclical, we should be advising that well-fitted underwear is worn 24 hours a day, with soft support at night and with increased support during exercise to reduce the amount of breast displacement. Topical non-steroidal anti-inflammatory medication is generally recommended as first-line treatment, and this can be used for 3 months. Oral paracetamol is also frequently recommended and should be taken 4 times a day for 2 weeks and extended for a further 2 weeks if it's helping. Pain diaries can again be helpful to try to monitor changes in symptoms with these interventions. There have been suggestions that factors such as caffeine or dietary fat intake, iodine deficiency, or smoking may also contribute to the development of breast pain, but this has never been definitively proven, and there is very limited evidence for dietary changes or supplements such as flaxseed, vitamin B6, vitamin E, and reducing caffeine. There is also a lack of proven efficacy for switching oral contraceptives or SSRIs, and for the use of diuretics or tibolone, which are other suggestions that have been put forward. If the breast pain appears to be a side effect of HRT use, then it might be worth trying a lower dose, and this may require a discussion about a compromise between control of menopausal symptoms and the breast pain. The question of whether evening primrose oil should be recommended is an interesting one. Evening primrose oil is rich in a substance called GLA, or gamma-linoloic acid, which has been found to sometimes help with breast pain. It's poorly understood why it may help, and some studies have cast doubt on whether there is any benefit. However, there have been reports of some women getting relief from their symptoms, and as it's associated with few risks or side effects, it is still recommended in several local guidelines. If patients are going to try evening primrose oil, then it's worth being aware that the daily dose of GLA is thought to be 240 milligrams, and this might mean that patients need to take several capsules daily, depending on the amount of GLA in the evening primrose oil capsules that they have purchased. It should also be taken for at least 2 months to see if it helps. Side effects are rare, however, some people do experience nausea with GLA, and it should also be noted that it is not recommended in pregnancy due to a small risk of miscarriage, epilepsy, or with anticoagulants, as it can sometimes increase bleeding tendency. It's also worth checking for interactions with any other medications that the patient is taking. Now, I've already discussed some indications for referral, but to summarise these, we should be referring patients with signs of breast cancer to an urgent suspected cancer clinic. And we should also have a low threshold for referring those with pain and a previous breast cancer on the same side to the same clinics. In addition, we should refer patients with a moderate or high-risk family history to a family history or genetic clinic, and we should be seeking an immediate assessment for those with breast abscesses, severe or non-resolving mastitis, or suspected sepsis. In addition, for those with cyclical breast pain that is affecting quality of life or sleep and that is not improved with 3 months of conservative management, a referral to the breast team would be appropriate. And this is because for those with severe and non-resolving cyclical pain, medications such as tamoxifen, GnRH analogues and danazol can be considered. But given the significant side effects that can be associated with these medications, their initiation should come from secondary care. For those with non-cyclical breast pain, we are encouraged to refer patients who develop a specific reason for their symptoms, such as a lump or evidence of an infection, as well as those who are experiencing severe and persistent pain. Finally, the management of extra-mammary pain requires a positive diagnosis and then treatment of the underlying cause. A referral to the appropriate team may be required if the management is beyond the scope of primary care, for example, ischemic heart disease requiring coronary angioplasty. So, thank you all for listening. I hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com, and would be very grateful if you would consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts, which are designed to help make your lives a little easier and ultimately help improve the lives of our patients in primary care.